Welcome to Mom Breaks. Today we are joined by Dr. Veerle Bergink, an MD PhD who is a leading expert in perinatal psychiatry with a focus on postpartum psychosis. Her work bridges clinical care, epidemiology, and biological research to better understand severe mood disorders around childbirth. She's a professor of psychiatry and of obstetrics, gynecology, and reproductive science at the Icahn School of Medicine at Mount Sinai in New York, where she directs the Women's Mental Health Program. Before joining Mount Sinai, she trained in medicine and psychiatry in the Netherlands and led an acute inpatient mother-baby unit, as well as the Center of Excellence in Perinatal Psychiatry at Erasmus University in Rotterdam. In 2008, she launched a landmark prospective cohort study of first-onset postpartum psychosis, the largest of its kind internationally, which continues to inform the field's understanding of the condition's onset, course, and biological underpinnings. Her research has illuminated factors such as sleep disruption, immune and hormonal shifts, and thyroid dysfunction, and has contributed to the development of structured treatment and prevention strategies. Beyond research and clinical practice, she's a prominent advocate for formally recognizing postpartum psychosis as a distinct diagnosis in the DSM, arguing that such classification is essential for early detection, treatment, and reducing stigma. She regularly engages the public through commentary and publications to expand awareness of maternal mental health and advance policy change. By integrating rigorous science with advocacy and education, her work continues to transform understanding and care for mothers and families worldwide. Welcome on the podcast. I'm so excited to have you here.
Yes, very happy to be here. Thanks for having me.
You've devoted much of your career to understanding mental health in the perinatal period. Can you share what motivated that focus for you?
I started working after residency as a psychiatrist on an inpatient unit, and we had 5 baby beds on that unit. So I saw, in addition to many other severely ill psychiatric patients, also women who were acutely admitted with postpartum psychosis, mostly together with their baby, sometimes without. We had voluntary and involuntary admissions, and it really hit me hard how sick these women were. At the same time, I was very happy to see that women after treatment completely recovered, returned to their prior functioning. Basically, 2 things happened. I was really shocked how many women, I would say most, did not have a psychiatric history. So for me, it was shocking. Like, why does someone after childbirth get so incredibly ill? And why does this happen so much? The risk is highly increased. The second thing that happened was these moms had understandably many questions, and their partners as well. These questions were same as me, like, why does this happen again? When they were acutely ill, they wanted the best treatment. They wanted to know what treatment options were available. They wanted to know if they would return to their functional level. They wanted to know later on what the risk for their own baby was. How could it be that it happened to them? So there were so many questions. So I started looking what was known about postpartum psychosis, and it was just shocking to learn that the disease officially not even existed, and that there were hardly any papers out there. There were some case reports and describing it, but there was nothing there. So that was such a shock for me. And yeah, I was very lucky because I had a colleague who had worked on the mother-baby unit for 30 years. So she learned me a lot how to treat the disease, what to tell these moms. Every time I asked, like, but why? And she said, yeah, because I figured out, that this worked, and because that's how we always do it. Then I thought, this is great that we're transferring knowledge from one doctor to another, but someone needs to do research in this area and take this more seriously. And given that no one was doing it, and I was heading the mother-baby unit with amazing team who was willing to help, I thought, okay, I did not have any research experience. I'm just going to do this myself. And I'm going to ask, get IRB, ethical consent, to do everything we're doing anyway, a bit more standardized. We were asking questions anyway, so let's do questionnaires. And we're taking blood anyway, so let's get some extra blood and store that blood. That's how I started it. That's why I really wanted to do it, to be able to answer those questions.
That's amazing that you were working with a doctor who had experience and to teach you. What were you taught then, and how has our understanding of treatment changed, if at all, since then?
An important thing is lithium. She said,
Yeah,
yeah,
okay.
women need lithium. And I asked, of course, why? Because many women were very psychotic, manic. And yeah, we know that in the acute phase, lithium works very well, but we know
Hmm.
antipsychotics work very well as well. So I asked, why do they need both antipsychotics and lithium? And she also learned me like to start, if you can, with sleep medication first. Most women do not get better only after 2 nights of good sleep, but it could be if someone comes in and is really psychiatrically
Yeah.
severely ill, that it's only profound sleep loss. I've seen that a few times. If
Really?
they, okay, you
Oh.
sleep through the night and someone recovers completely, then you can say, okay, this was super short. This is not postpartum psychosis. So
Oh.
she learned me to treat with antipsychotics and lithium. She also learned me to say that women will get better, yeah, and also on the long term, because she had been there 30 years. So she had followed up these women. And she said, yeah, it's associated with bipolar disorder. But yeah, again, there was hardly anything there. So, and of course,
Hmm.
I saw that myself as well. I was a psychiatrist. So it was that I needed her supervision. When I took over her job, she told me all those things which could not be found in the literature at that time.
There wasn't a clinician's guide to treating postpartum psychosis at the time.
Not an
You,
evidence-based clinician's guide. And I have to say, until today, there are not clear, people write a lot about postpartum psychosis, but there is not like official guidelines or guidance how to do it.
yeah. Yeah, and that's coming up. I've been interviewing survivors, and each person, there's not like a standard of care because people are getting all sorts of medications and treatment.
Exactly. And that is extremely weird in medicine, that we have a very severe disease and that any doctor is going to do whatever they feel or what is their opinion. That's very
Yeah.
weird, especially because most psychiatrists do not have experience with postpartum psychosis. They should be able, like for any other disease in medicine, to have evidence-based guidelines saying, okay, this is the first step, then you're going to do this. This is what we recommend. They cannot use their own, it's not that they have seen hundreds of patients and that they learn themselves. There
Yeah.
really need to be guidelines.
Well, I think it's tricky because a lot of women go first to an emergency room or a local hospital and not into a perinatal psychiatry specialist center. General psychiatrists who don't specialize in postpartum disorders, like mine, just had never. He was like, I don't really know what this is. It makes sense. I think there's systemic education needs that could help have more consistent standard of care and also identification and giving people language, not even clinicians, but also the survivor or the patient to understand what's happening to them. You're the director of the Women's Mental Health Center at Icahn School of Medicine. Can you share what your work there looks like and when women usually come to you for care?
Nowadays, most of my work is research. So there are
Okay.
several principal investigators in the Women's Mental Health Center. We collaborate on several topics related to women's mental health, such as menopause, pregnancy, postpartum. That is clinical research. We do clinical trials, large database research. I team up with a lot of people and try to help. Part of my job is also patient care, but being director of the center and also like we all research do grant writing, trying to secure funding is such a large part of my job. I do not see that many patients. I'm not doing inpatient care. I see outpatients, either women who have gone through postpartum psychosis and specifically come for me for that expertise, or other women who have a preference to be treated by me, but I'm not seeing that many patients.
Wow, they are lucky to have you.
I really like patient care. I started research because I was doing patient care and I wanted to get some answered. And that
Hmm.
kind of 20 years later got a bit out of hand, that now I find myself mostly doing research instead of patient care. I think it's both meaningful, and at this stage, there is such a need for research that I'm really motivated to keep doing this. I'm talking about postpartum psychosis, but also women's mental health topics more broadly. So
Yeah. Yeah. I feel like something that kind of surfaces as you look at postpartum psychosis is it's like a microcosm for a woman's health generally. It's like we need more resources. We need systemic solutions. We need people working on this from all angles. I'm so glad you're doing the work you're doing. You.
thank you. Same for you. I mean, you're doing this work for the same reasons, right? Because you want awareness, you don't want other
Yeah,
people
I
to have a negative experience. So I think that holds true for many people in this field.
well, that's what I'm hoping. I feel like it was hard for me to navigate all the questions I was left with. And so, anyway, I hope that it can be helpful. It is very early, but I'm motivated to help and create solutions for women to feel educated, families to feel educated on what postpartum psychosis is. With that in mind, how do you define postpartum psychosis?
It's the acute onset, usually within 2 weeks, but we proposed for the criteria within 3 months or 12 weeks of severe psychiatric symptoms. Most women have severe mood symptoms, mania or a mixed episode, can also be high irritability or thoughts racing. So the acute onset of mania or a mixed episode, or other severe mood symptoms such as psychotic depression right after delivery, which is the first 12 weeks after delivery, very different from the functioning before that time period.
Mm.
And so the symptoms can be variable, but the onset is clear and the severity is also clear. Some women are only manic, but most women, the vast majority, also have psychotic symptoms, which means that they at that point lost reality. It can be that their behavior is very strange. It can be that their thinking is not as it used to be, or it can be that they have ideas that are clearly not correct or
Yeah.
weird, and can also be hallucinations, so seeing or hearing things they otherwise not see or hear. It's really a severe mix of symptoms, which have all in common that they specifically occur during this period.
Hmm. You already mentioned the association with bipolar. Can you say more on the relationship?
The relationship with bipolar goes two ways. Many women we see on mother baby units worldwide and do not have a psychiatric history. They deliver often their first child and get all of a sudden severely ill, and all women get better. But after they get better, we know that some women only had these episodes and that was it. Or maybe they get it again if they're pregnant again. I think about half of women only have these episodes. We also know that the other half of women have ongoing psychiatric problems during their lives, and that is mostly either bipolar, so having mania and depressions later in life,
Hmm.
or bipolar related, or severe mood disorder related. Even though their acute episodes can be, not in terms of phenomenology, look as bipolar disorder so much, we know that in the longer course, many women end up with a bipolar diagnosis. Many women do not have symptoms anymore, but some women look back 5 years after their episode or 10 years and say, unfortunately, this specific episode was the first onset of bipolar disorder. They only know
Hmm.
this, of course, later, but Yeah, in retrospect, I say that was the onset of bipolar disorder. This was the first episode. So in these women, childbirth triggered bipolar disorder, starting
Yeah.
with postpartum psychosis. That is the first reason why it's related to bipolar disorder. Another reason is that women who have bipolar disorder, many patients get diagnosed in their early 20s, for example, or around that time, early adolescence. When they get their first child, they know they are at high risk of getting severely ill after delivery and that the risk might be lower during pregnancy. We do not know why that is for bipolar disorder specifically. Because if we look at all other disorders in psychiatry, of course, childbirth is a major event which has an impact. If you have vulnerability for depression, childbirth can have an impact as well. But for depression holds true that it's also very common during pregnancy, that it's very common at other times as well. It's not so specifically that the period after delivery is a high risk period. For other severe diseases such as OCD, we don't see such a pattern for OCD. Of course, it's a major life event. A lot of is happening. And if you have any mental health disorder, then yeah, that's going to be,
it can
for
aggravate
any
it.
person with or without mental health disorder, it's transformative and life-changing to have a child, especially if it's your first child. But for women with bipolar disorder, it comes with an additional risk, and we do not know why that is. So that is the relation between postpartum psychosis and bipolar disorder.
Yeah.
And also, this relation is not there so much for schizophrenia, for example. Whereas you would expect that, right? Because it's called postpartum psychosis. So you could think, oh, yeah, that's a psychotic disorder. And it can be very severe. Women can really lose reality, which makes you think like, oh, what is happening here? Is this the first onset of schizophrenia, for example? And we do not see that in clinical practice.
A few follow-up questions. You recently published this clinician's guide on bipolar disorder in pregnancy. Can you share what best practices are for treating pregnant individuals with bipolar?
Yeah, for bipolar disorder, even though pregnancy is not a specific high risk period, it's still very important to maintain mood stability during pregnancy because we know it's just horrible for women if they're not well during pregnancy. And the second reason is also we know if you're already unstable during pregnancy, that puts you at risk for having instability, especially after delivery. So the best treatment for women with bipolar disorder, they will have to discuss to continue their medication during pregnancy to maintain this mood stability, which is important at all times and also during pregnancy. What is, of course, complicated during pregnancy is that you really have to think, and women think about this, of course, all the time, but what this will mean for my
The baby.
my unborn baby, and what effect do these medications have? So we know that some bipolar medications, for that reason, for example, valproic acid, should not be used in women in their fertile ages because that is a bipolar medication which is teratogenic, highly teratogenic, meaning, yeah, that if you can avoid it, you should not use it. And we also know that unplanned pregnancies are common. So yeah, in general, during pregnancy, women with bipolar disorder are always searching for not too many medications at the same time and search for the lowest dose.
All right, teratogenic is referring to teratogens, which are substances that interfere with typical fetal development. So if you are exposed to these during pregnancies, this can include medications, chemicals, infections, toxins. They can increase the risk of birth differences as well as pregnancy loss and preterm birth. Just a quick plug to be proactive in your health. Take the time to check in with your providers, schedule your annuals, get your lab work done, ask questions, review your supplements, whatever you take, and yeah, schedule that next appointment. It's part of caring for yourself, and that, type of intentional care can support your long-term well-being through every stage of life. So take care of yourself.
What is our current understanding today as to what you can take through delivery versus where you need to adjust? Like if you're on lithium, do you need to bring it down when you're about to have your baby? Or do we understand now that you can take a medication through delivery and beyond?
So any medication you take will, passes the placenta during pregnancy. So what to do is a bit different for every medication. But for example, for lithium, we know that during the first trimester of pregnancy, lithium can be harmful for the baby in high doses. Not as much as other medications such as carbamazepine or valproic acid, but still. So during the first trimester of pregnancy, if you're on lithium or if you wanted to go pregnant, you want to keep your dose low. Then during pregnancy, it's going to be a bit lower anyway because of the change in kidney functions. And yeah, you might accept it. And then we know that at the end of term, your lithium blood levels will go up. So you should monitor that to make sure that it's not too high. During pregnancy, lithium levels do not need to be high. As I said, preferably in the first trimester, they're low.
Low.
And then, yeah, when you deliver, is no need to hold your lithium. But then after delivery, it's best if lithium levels are high because then your high risk period starts in a way. And you're not pregnant anymore. So you do not have to worry about the transfer
To the baby. Can you share? I just was talking to someone about how they were able to take lithium while breastfeeding. Can you
Right.
say anything on best practices there?
Yes, I will try. You might want to invite someone else on the show.
Yeah.
I've done a lot of clinical care, mostly in the Netherlands. At that mother-baby unit, we did not encourage lithium
Okay.
and breastfeeding. There is some transfer of lithium in the breast
In the
milk,
milk.
but also for the reasons of sleep loss, which were
Oh.
most if women are taking lithium as prevention, if women were severely ill, as in admitted to a psychiatric unit, we felt like the benefits of breastfeeding do not outweigh the risks of breastfeeding. And that is that, that it might take longer to get out of this very severe episode. The other thing is if you do not completely are able to, yeah, have good feeding schedule or pump completely, you end up with mastitis. I've seen that many times as well. So we have seen some real challenges with
Yeah.
breastfeeding. That is why we also, with a group of authors, wrote a paper saying, is breast always best? And if you
Yeah.
ask me personally, then the answer is no. Of course, it's beautiful if you can breastfeed and do not have many risk factors. Fortunately, many women with mental illness can breastfeed and it works well for them. We should all strive for that. But at the same time, there can be sometimes, dependent on where your care is, a lot of pressure
Uh-huh.
through the breastfeeding.
And
Again,
sleeplessness.
if we're talking about severe risk, I think we should weight the risks correctly, right? So I usually advise women what I would do myself or what I would advise to a close friend or my daughter. I would not do it if I was at really high risk. So,
That's
but
a great
having
point.
said that, there is increasingly good knowledge on how to treat with lithium and combine this with breastfeeding. If you're either, on a specialized unit, have a doctor who has experience with it or a neonatologist who has experience with it, then it works really well. And I have also, for example, colleagues from India saying to me, yeah, but what if the tap water is not safe and or
Oh.
it's too expensive, formula feeding, and then it's a completely different weight of risks and benefits of breastfeeding. So I think that should be individualized on what the situation is. And also
Yes.
what your risk is, right? And what your underlying illness is. And yeah.
Okay, that's really great. Thank you for explaining all of that. One other question that came up from a previous interview was whether experiencing, because you can have bipolar and not experience psychosis. Is there any impact to the progression of bipolar if you do experience psychosis? There's probably not research there.
Yeah, no. Well, in general, we know that having less episodes is always more. It's better
Yeah.
than having more episodes, right? That's not rocket
Yeah.
science. So yeah, just being horrible for yourself and your family and everyone involved to go through this. It's also, in general, if you have a psychiatric disorder, not great to have more episodes. We
Right.
strive to keep that limited. Then
Hmm.
I don't think it's investigated if that is different than having another episode in your life if you have
Yeah.
bipolar. You see what I mean? So,
Yeah.
but the
Okay.
difference with other episodes is that you can see this one coming. For many events in life, which are stressful or otherwise a trigger for a bipolar episode, you cannot prevent anything. Life is happening, but I feel motivated to provide treatment recommendations and inform people because we can see this one coming with 9 months. That not only holds true for women with bipolar disorder, but also for women who had postpartum psychosis in the past, right?
Hmm.
Because that is also a large group of women having questions like they had postpartum psychosis, they did not have a prior diagnosis of bipolar disorder, they do not have a diagnosis of bipolar after their postpartum psychosis. Yeah, some women unfortunately do because in this weird classification system, they get the diagnosis bipolar right away while they actually
Yeah.
have postpartum psychosis. But let's say they did not have any episodes, then many women, in my experience, are successful in completely tapering their medication. They can stay off medication during pregnancy, which is good to know. If they only had a postpartum psychosis in the past, but not a full bipolar disease course, they can have no medication during a subsequent pregnancy. But then
Hmm.
after delivery, I would recommend to prevent postpartum psychosis
Prophylactic.
again. So, and that is, yeah, that's the same story. I mean, women and their healthcare providers have 9 months to see this coming for a second time, and then it should be prevented. But as you
Hmm.
said, you had been, well, you have not been lucky, obviously, to get postpartum psychosis, but you have been lucky in terms of having the resources to learn more about it. But that does not hold true for many women. And even
Right.
though they have 9 months to see this coming, they did not, and neither, and that is, I think, particularly bad, did their healthcare providers or anyone say to them, like, okay, you have had this, we should prevent this a second time. And not only a second time, I've seen women who, I have to say, mainly for religious reasons, so women who
Oh.
are very religious, and that has been Christianity, Muslim, Jewish women, who got like 5, 6 children, and every time they got severely ill. And
Oh.
that is not only saying to me as a researcher, like, okay, you see that there is
Pausing.
something as a yeah, child space, in addition to all the evidence there, of epidemiological studies and other studies. So on a research level, it's like, wow. Also, of course, on another level, I feel so sorry for these women that this is happening over and over again, and that
Yeah.
no one is helping them out to prevent this.
Hmm. Yeah. So with prevention, if we were talking about prophylactic treatment for someone who has experienced psychosis in the past, does that look like lithium? Is that the gold standard?
That is because
Okay.
lithium has been best investigated, and we know that it works really well.
Mm.
So what we want to do is investigate antipsychotics, because that's what many people are doing in clinical practice, because many clinicians have more experience prescribing antipsychotics. So what people are doing, if they're doing, unfortunately, most people are not giving prophylaxis, but if they're giving prophylaxis, then people are giving antipsychotics. And even though lithium is the gold standard, very few people are doing it. And we published about it. We showed that if women start lithium, they do not get ill. In our large case series, no one got ill. We desperately need this data out for antipsychotics. So yeah, what I would do, I would take lithium because that would be my first option. But yeah, at the same time, I also really want good data out for other options. We know, for example, that valproate didn't work. That has been investigated as well. So that's another reason not to use it, in addition for not using it during pregnancy.
Is that an antipsychotic?
That's valproic acid. That's an anti-epileptic, and that has been used in treatment of mania a lot and for bipolar disorder. There is a study out there showing that it doesn't work. We need this information for antipsychotics, but also, for example, for lamotrigine, which is also a bipolar medication women with bipolar disorder are using. We did one study but that was a register-based study. And that suggested that it might work as well as lithium, but in the end, we don't know. We need more data.
Can you share about your involvement in getting postpartum psychosis into the DSM?
Yes, everyone working in this field or mother-baby unit is always saying like, yeah, this should be recognized. So as clinician, like all other colleagues, I follow this opinion, but why I got involved in the process of trying to do this is because I was recruited at the Icahn School of Medicine at Mount Sinai 8 years ago. So then I worked in the US. And there was an initiative from a professor in Columbia, Max Spinelli.
Yeah.
But she did this on her own. That did not get her proposal that this should be a separate disease code rejected. But at that time, the Severe Medical Illness Committee who was reviewing it already before the rejection, when they said, yeah, no, it's a very important topic. They asked for a revision and they asked me, given my research experience, like, could you help to also start working on it? So I met with Dr. Spinelli, given that she had been working on it for so long. She said, I'm going to finish this process. And I said, we need to pull in a lot more people worldwide and a lot more research. She said, no, I'm going to send in my revision. And then it got rejected. And then we actually did start work on it with a large group of professors in this field specifically. And there are not many people worldwide who are expert in these, but I just called them all like, do you want to help out? Because this is going to be a lot of work. And it's important that every one of them said yes, even though it's voluntary work. Everyone is leaders in the field of women's mental health research, but also women's mental health clinical care. So they are super busy people. So normally when you propose something that is not going to lead to any immediate benefit or even uncertain long-term benefit and is unpaid, that is not a popular thing to ask from people, right? Because everyone feels so strong about it, like this really has to happen. We have been working on it now for 5 years and really motivated to make this change because this change has to be made.
Yeah.
We really need the current classification is a huge problem in this particular area.
Yeah. Did Dr. Spinelli get any reason for why it was rejected?
Dr. Spinelli at that time, I think one of the reasons was that the link with bipolar disorder was not enough highlighted, but I did not see the reports. Even though Meg and I are in close contact, we keep each other posted, but I didn't, because we decided to start all over again. So it's not that we took that proposal, we just started from scratch to do a literature search on this topic together with all the people who have actually also published a lot on this topic. So
Okay.
yeah, we started all over. So yeah, a lot of people have put a lot of work in this.
Thank you. While you're directing a women's health center and all your research, I didn't think about it being unpaid work that you're all doing to get that.
Yeah, no, but I just want to emphasize that it's not me. I mean, I ended up, leading it, or I started leading it. It's really many people, and it's more people. The paper we wrote for biological psychiatry, we have been working on it with nine
Many
professors,
people.
nine full professors for 4 years. But when we wrote that paper, researchers working on the topic were pulled in, but also people, for example, who were involved in the national curriculum, so educated residents in psychiatry, which is super important work because we discussed like everyone should know this. They
Yeah.
also immediately said, yeah, let us help write this because we have summarized this in our repro track. So basically, everyone I talk to say they're fully on board, or they contact me like, what can we do to help? Also, people leading our perinatal societies, like the Marseille Society leading the North American Perinatal Society, which is called MONA, leading the International Association of Women's Mental Health. So basically, all major women's mental health organizations and their leaderships are really support
Behind it.
on board
Yeah.
and help making this happen.
That is fantastic. And it's wild to me that it's taking this much effort and years to,
I know I'm a very impatient person, so personally, it's difficult to be patient. At the same time, I fully acknowledge that it is
uh-huh.
important that, given that it has any classification in DSM, has major impact on the field. We also see this now, postpartum psychosis not being classified, what the effects is. So
Mm-hmm.
any change in the DSM should be carefully thought of.
Yeah.
Yeah, and
Yeah.
the length of that process is not
Long.
something which we cannot influence.
Yeah. Can't control.
No, we
Yeah.
can't control. The outcome in the end, we can't control either. All I can do is continue doing the research, continue doing the advocacy, making the case, getting it out there, publishing about it,
Uh-huh.
like we're doing now, just talking about it. And
Yeah. Getting in there. I'm really grateful for this work so that we have better data around postpartum psychosis, which I feel could get us a better global estimate of how often this is happening, which then could fund research and bring more attention potentially. And that's from a bias that I feel like it's bigger than. I wonder if we have higher occurrence of postpartum psychosis than this stat that we keep using that like originates from 40 plus years ago. What's your reaction to that?
it's not only 40 years ago, but
Oh,
we also have data from Danish and Swedish databases like first time inpatient admissions, um, which
that
occurred
verifies.
specifically in that period. And then, so that is might be quite accurate, but it is dependent on inpatient admission. Otherwise, you do not end up in those numbers. And given that the diagnosis has so many different codes, it's really prone
Hard.
to errors.
Yeah.
But we know that worldwide psychosis and mania occurs, I think, at least 10 times more often during this specific period, what is called postpartum psychosis, than
Yeah, more
at
likely.
other times in life. So I fully agree with you that we need the right numbers out there and detect it. And of course, if we can prevent it in women at high risk, yeah.
Yeah.
So I will include a link to one of these Swedish registry studies that Dr. Bergink referenced. A large population-based study published in 2009. They followed hundreds of thousands of first-time moms in Sweden and replicated the occurrence rate that we've talked about before. They found that psychosis severe enough to require hospitalization affected about 1.2 per 1,000 births. So that's great. I'm glad she pointed me to this. They talk about how the risk is much higher for psychosis in the first few weeks after delivery, and then decreases from there. And they found that nearly half of the women hospitalized did not have prior psychiatric history. So they kind of spotlight how it's important to monitor all moms, especially during those first few weeks after giving birth.
One other follow-up question on this DSM proposal. As someone who's experienced psychosis who has not had a bipolar diagnosis, I'm curious what you think about having postpartum psychosis in the bipolar chapter and whether that will create. I'm wondering if there are women who are put under bipolar, not realizing that they aren't necessarily going to develop bipolar. What's your reaction to that?
Well, first of all those women with mania currently get an incorrect diagnosis of bipolar disorder right away during their acute episode. So I think having postpartum psychosis in there as a separate diagnosis allows at least all of us to not immediately diagnose bipolar 1 disorder, but say it's a postpartum psychosis, which is not the same as bipolar disorder. We would be very happy if it's a separate chapter, but the way the DSM, and that was what we were told, is organized is that, you have to either put it in the bipolar chapter or in the psychosis chapter, in the schizophrenia chapter. We do not have a separate chapter on women's mental health or postpartum psychiatry. So I think that is one of the issues. The other issue is that Max Spinelli proposed it as a separate chapter. That did not happen. All of us also say, okay, as long as it's in the
It's in.
DSM,
Yeah, we'll take it being in.
Yeah, we can, because we all want the same. You
Yeah.
see what I mean? We want the same as the DSM committee, and everyone wants this to classify this as good as possible. An advantage of the bipolar chapter is that women are aware that there is a high chance that
A connection.
for example, lithium is hardly used in the United States anymore. So an advantage of having it in a bipolar chapter is that women, if they need it, get mood stabilization.
Okay.
Yeah. If people are worried and say, but then I get immediately a bipolar diagnosis, for us as this working group, the reason for arguing for this disorder is that we want to have it correctly classified, and we don't want an overdiagnosis or underdiagnosis of bipolar disorder. And both things are happening now, because women with depression with psychotic features, no one thinks, this could be bipolar related if it's in the postpartum period, whereas there are, like all women with postpartum psychosis, just at high risk moving forward of getting bipolar. So people should think about it. They should know. Should know, like, okay, this could happen in this group. Bipolar, people see it as depression. They don't see it as the severity. And that is not okay. The acute phase is not treated with lithium. During follow-up, people do not think about bipolar disorder. That's a problem.
Yeah.
So, but I hear what you say. People are, but I have seen many patients who had mania after delivery, like one single episode, who were told by their doctors, you have bipolar 1 disorder. And I've even had women who was on a mood stabilizing medication for 20 years, really having impact on every aspect of her life, thinking that she had a diagnosis of bipolar 1 disorder, which I think, and she thinks as well now, was not the right diagnosis for her. So that is a misdiagnosis.
You've explored how the immune system and thyroid function play a role, or could play a role, in psychosis. Could you explain what that means?
For some women, their thyroid plays a role. It's unclear if it's the most important trigger. So they had autoimmune thyroiditis, postpartum thyroiditis, which means you have an autoimmune attack of your thyroid. after delivery, which happens a lot. A few percent of all women who deliver a baby have thyroid problems, but that can contribute to postpartum psychosis. So we see that can be one of the factors. So clinically, given that it's such an relatively easy thing to screen for and also to treat, people should think about it. And with regard to the immune system, thyroid problems occur so much after childbirth because that is a time in which autoimmune disorders occur anyway. For autoimmune thyroid disorder, which is called postpartum thyroiditis, it's, like I said, relatively easy to treat, and in some patients it goes away. But many other more serious autoimmune disorders, such as multiple sclerosis or rheumatoid arthritis, they also have their specific onset after delivery. So basically, in general medicine, all disorders with a specific onset after delivery are immune-related or autoimmune in nature, which of course raises the question, like for postpartum psychosis, in addition for
other risk
female
factors.
hormones, which play a role, which we know that has an impact on your health, could it also be the immune system, which, is it an autoimmune related disorder?
Yeah. Can you say more on how inflammation or immune changes after birth could influence the brain?
Well, it can influence the brain via, during pregnancy, your immune system is a bit suppressed or differently organized. Otherwise, you would reject your own baby. So after delivery, that goes back to your normal immune system. And it means that, the immune system has to reorganize again. Your innate immune system is still high, like it was in pregnancy, and your adaptive immune system is coming back again because you don't have to suppress it anymore, given that your baby is out. So there is a period in which the immune system is stimulated. Well, how this could impact the brain, we saw in some patients like a direct autoimmune attack on the brain. We literally could find the antibodies against the brain. So meaning the brain is on fire, there's a acute autoimmune attack on the brain. Other impact of, and that is the whole field of immunopsychiatry, is that inflammatory mechanisms, inflammatory cytokines can pass the blood-brain barrier, being in an inflammatory state, which we know from people who are sick or have an inflammatory disease. It can lead to brain changes as well, which are way more difficult to detect, as in you cannot easily or not see it on a scan or in blood or in cerebrospinal fluids. So there are multiple mechanisms in which they could work, but there is hardly any research. So we need to start investigating this.
Yeah. Are there specific biomarkers or pathways that you feel are like the next area you want to focus on?
As I said, the immune system, but that is wildly broad, as you know.
Yeah.
There are many pathways. There are, of course, also a fall in sex steroids, in progesterone. We know that that there is hormone sensitivity, that there are some women who have like specific hard time during menopause or before menstruation. So that is something we should investigate as well, those pathways. And then there is, for example, serotonergic pathway, tryptophan, which is an interface with the immune pathway, which is changed after delivery as well. So there are many clues, and we should investigate all of them. If you ask me where to start,
sure, it's unfair.
What I am doing, that we're really looking at also genetic changes and how genes are expressed. We plan to look at epigenetic changes. I teamed up with a colleague who is really motivated to do the animal work, to be able to do this in an experimental design, the genes, because we know for all psychiatric diseases often start with having a certain genetic vulnerability. Then when and how does that get you over the threshold? So this is it's a very clear hit, right? So you have a genetic vulnerability, then there is this hit, and why does this get you specifically over the threshold and which genes are specifically
The culprit.
changed in their expression in this time period. So you almost have to start then with the normal physiology of pregnancy and the postpartum period and all the changes taking place there. And then you can say, how is that different for women
who do develop
postpartum psychosis?
One thing that I've heard in survivor circles is, and I know Pitocin is standard. It's involved in most deliveries. It's very common in the United States anyway. And some have wondered about, on the topic of sex hormones, that of course oxytocin system like that there, and I've looked and it looks like there's different research on the role of oxytocin in psychiatric disease. Have you seen that in your work? Like wondering.
Yeah, of course, we also have been wondering about both oxytocin and prolactin, which are changed as well and are related to breastfeeding. We
Yeah.
know they have a major impact, mostly investigated for oxytocin on mental illness. More research is needed there as well. I also have a colleague who's doing that specific work, who's writing grants in mood disorders, postpartum more broadly. Like, does this have an impact if women get this? What I do know from my own research is that we cannot find, because all women are advised to start breastfeeding after delivery, we cannot find that some women do not start for some reason. It's not that the women who start or who do not start breastfeeding have different rates of postpartum psychosis. You see
Right.
what I mean? So
Yeah.
it's not that the
Easy to
decision to
study.
breastfeed or not to breastfeed right after delivery increases or decreases your risk, as far as we know. But that's also, again, small groups, difficult to investigate in large groups. But yeah, it's definitely, and I'm happy you bring that up, very interesting to further investigate.
Yeah. I listened to a podcast you were on within Mount Sinai, and you were speaking to risk factors for who is vulnerable to develop postpartum psychosis. Can you share your thoughts there? Like what you've seen as far as the distinction between risk factors for depression versus risk factors for psychosis?
For postpartum psychosis, the risk factors, you are very high risk if you had a prior episode of postpartum psychosis and or if you have been
Bipolar.
diagnosed with bipolar disorder. That is very high. Then your risk is 1 out of 3. Your risk is increased, but still very low in absolute terms if you have a first-degree family member who had postpartum psychosis. Then your risk is 10 times increased, but it's still very low given that, you know, the baseline risk is quite low. And then all other risk factors described in general psychiatry as in, I don't know, having a personality disorder or difficult financial circumstances or socioeconomic status, those do not play so much a role in postpartum psychosis. Of course, none of it helps, right? Life
Right.
in general is so much easier if things are going well for you in life.
Yeah.
We do not find those classical risk factors for postpartum psychosis because we see it among all cultures and education and income levels. And so all these risk factors do not play a very large role there. Yeah, and sleep loss is a risk factor, but it's also difficult because it's one of the first symptoms of the disorders.
Right.
So is getting
both.
not well. So both depression and psychotic features and mania and psychosis comes with sleep loss and thinking a lot. But yeah, I think that's very likely that extreme sleep loss and extreme stress at the period of delivery is a risk factor.
I'd love to hear as we wrap up if you could design one policy or cultural shift to improve outcomes for families around perinatal mental health, what would it be?
We definitely need specialized postpartum expert centers and clinical facilities to treat women with postpartum psychosis, and also for women with really severe postpartum depression. That is absolutely needed. Clinical expert centers, we can do research there as well. So that just needs to be built
Mm,
everywhere in the world, but specifically in the United States, because
it
we
doesn't, yeah.
know that it doesn't exist.
We're
And
behind.
yeah, and there are some initiatives, many clinicians doing heroic work, such as Catherine Behrendorf and
Yeah.
some more El Camino in North Carolina. I mean, and I can name a few, but given how large this country is and how many facilities there are, that will make such a difference. Even if you're not interested in mothers and babies or don't care and you're only interested in money, then still it would be a very
Oh.
wise investment for
Oh,
everyone.
yeah. You're
So
pitching it
also in
already.
terms of policy making, it makes a lot of sense.
I hear you. So what are the barriers then? What do you see as the biggest barriers?
The biggest barrier is that we have too many modest and nice people working in women's mental health, maybe not
Oh.
shouting hard enough and making this case and pushing hard. It's a very collaborative and friendly field. And I feel we should get a bit more,
Loud.
yeah, making that clear, because I think we do need a loud voice to actually make that happen, because we're now at the stage that no one openly disagrees, like says, oh, no, I don't think that's important. But it is not happening. So we need that.
Yeah.
And then, of course, like always, we just need money to make that happen. Money goes a long way. If we can find the funding, if we get resources on all levels, then we can make that happen. And we have seen this for many other disorders in medicine, that
Uh,
there has been like a huge change if the resources become available. So
right.
yeah, we have to go for it. There are many challenges in the United States, but the message is worldwide. I mean, even
Yes.
also in many other countries where they do have some very good treatment facilities, it's really not enough. It's still, their resources are incomparable to other treatment centers, and there's very few research on those mother baby units. They're training people in clinical care, but not in research. So there is not, like for disorders like, let's say, multiple sclerosis, right? It's a bit
Yeah.
more prevalent, but not that much. There is so much people getting trained, doing research, expertise centers in one country, sure, is better than the other. But here it's, unfortunately, across the globe, it's just, in some countries, it's even more neglected than others. But also in countries where I have worked, such as the Netherlands or Denmark, it's just not where we should be. And so, yeah, that keeps us all very motivated to
Hmm.
make the change, and we will get there, but I think we should speed it up a bit. And I
Yeah.
also, to end maybe positive note, people are picking it up. I see last year's a change in advocacy and people speaking out loud, and those are both women and men. So it's not only a women's issue. Men are speaking out as well, saying like, yeah, this should happen. Women are speaking out massively, if they have gone through it or they heard about it or they care about it. Women's leaders are speaking out like, okay, this really has to change. And ultimately, this actually leads to calls and research. We're starting to get there.
Would you leave any other call to action for families or advocates around postpartum psychosis?
Everything helps. So if people share their stories and not suffer alone, seek each other's help and join patient groups, and then make sure that their voice is heard. And yeah, and of course, people who are in positions that they have like influence politically, or they are lucky enough to have a lot of money, then they could think of what each of us could contribute to make that happen. Yeah, and what I can do is, because I'm in the research field, try to keep going and keep myself and others motivated, keep doing this work.
Yeah, yeah. I've loved getting PSI has a Mind the Gap newsletter
and they will send out like, hey, we need people to sign. Congress is passing a bill that's
They
providing
are
funding
doing
for
amazing work, right? That is
Yeah.
fantastic what they're doing. But yeah, also that work is voluntary, right? There are also people spending a lot of time, which is okay, but it helps if more people join, if everyone weighs in with their own expertise and strength, that just helps. It's just a matter of keep doing it.
This is a kind of a tactical question. Does your funding come through the NIH usually, or are there ways that people could donate to fund research on postpartum psychosis?
We're working on it. So I
Okay.
will let you know and give that link because that would be hugely helpful. I've reached out to our office, like, okay, also, we need, and then just to make sure that money will go specifically then to research for postpartum psychosis. My funding currently comes from NIH, and I'm very grateful to NIH has been super generous for my work in general. But when it
Hmm.
comes to postpartum psychosis, we got small grants, but
Oh.
there is no National Institute of Health large grant on postpartum psychosis, I think worldwide even, nor any
Oh.
other funding agency having, seriously funded it. Maybe the Wellcome in the UK did something. I know a colleague of mine has a grant there, but other than that, worldwide is just not funded, which is
Oh.
insane. And yeah,
How
and
do
again,
we
I
change
don't want to
that?
complain about my funding because I find
No.
the US system awesome. And both the CDC and the NIH have funded many of our projects. So I'm doing many other things to bring in the funding, but I think now is the time to actually get funding for postpartum psychosis.
Okay. So like some institution driving, advocacy and being in those circles to get funding from the federal
Yeah,
government
absolutely. And
is
of
needed.
course, and it's always this collaboration is there, right? So we have laid out this network now, all those institutions working so long on this DSM criteria. So we
Hmm.
all really work well together. So
Yeah.
in terms of being serious of really making breakthroughs, of course, that's not going to be one institution. That's always going to be a teamwork between preclinical people building the animal models, genetic people working with big databases and trying to replicate each other's findings. And we know in
Hmm.
genetics that should be multiple databases, large registers in the Scandinavian countries, clinical cohorts such as my own in Rotterdam, but also India started a cohort, and others should also have the funding to just follow up the patients and
Yeah.
they're seeing. And then, like I mentioned, prevention is antipsychotics as good as lithium. That's another example. We teamed up with Baylor in Texas, with Mass General, who have an excellent women's mental health center. And so we teamed up with UNC, North Carolina, who have an
Yeah.
excellent mental health center. Those are pending proposals, and all that should all at some point be funded. It's never going to be a single center. These collaborations, it's not that we are inventing the wheel. That's super common in medicine in general. You have a disease that is not super common. People team up, build networks, and have expertise centers
Get
and
it on the
do
map.
research together. Yeah, and
Yeah.
replicate each other's findings. That's also very important. We want
Hmm.
things that are sound, and that
Yeah.
is, we're getting there.
That's amazing to hear of the synergies that are developing across states and countries. I'm so
Yeah,
grateful for
no,
it.
absolutely. That's what I was saying. I might
Yeah.
have been too negative, but my colleagues saying that the
No,
field is too
no.
nice and too friendly, and that we should make it harder push. But the upside of
No.
this is that we're really able to collaborate
Yeah, like good
well
work is
and
happening.
pull that
And
off if we get the funding.
I guess I was hearing like there's probably like foundations for pancreatic cancer or like thing that probably
Absolutely.
exist. And there's probably
Yeah.
not that for postpartum psychosis. I
No.
don't think so. Thank you so much for all this time. We did not even hit all the questions, but this was a fantastic conversation. So we wrapped our conversation and I had a few pending questions. Dr. Bergink was really kind to respond to these asynchronously, and I'll share her responses. But want to first share what I asked. So wanted to understand how lithium
facilitates mood stabilization. So like how it interacts with a dysregulated immune system, whether she foresees immune modulating therapies being able to augment existing treatments for PMADs. And if we could foresee a future where we use thyroid antibody screening and immune profiling to be part of prenatal care. And then why postpartum psychosis can result in lifelong bipolar disorder. Why would this be? Is there some sort of permanently altered immune system shift? And how does this tie into perimenopause and menopause? So like hormonal changes to consider for that time of life. Here are her responses.
How lithium, exactly works for mood stabilization and for interaction with a dysregulated immune system. That question that we need more research into lithium in general, which isn't sufficiently funded given that it's an element, it's such a cheap medication. So in general, there needs to be more research on immune modulating properties of lithium. Other immune modulating therapies are currently tested in general psychiatry, and you could imagine that it's a bit easier to do treatment trials at other times and not in the postpartum period, and there are some promising compounds out there. Once this research is a bit further, we could think of doing treatment trials in women with, for example, postpartum depression or postpartum anxiety with immune modulating treatments. And we do this only as next step because the postpartum period is such a challenging period to enroll women into research given all the things that are ongoing. What is relevant for clinical practice is that thyroid antibody screening, currently we recommend it after delivery, is important to identify autoimmune thyroiditis, which is a risk factor for both postpartum depression and postpartum psychosis. Currently, the screening is not part of prenatal care, mainly because thyroid antibodies are lower during pregnancy. And with regards to immune profiling, we're not there yet in psychiatry that we can say anything meaningful about it. There are no immune markers in psychiatry in general with sufficient clinical relevance and sensitivity and specificity. And that is because psychiatric disorders, we know that the immune system is involved, but these are not clear autoimmunities, for example, such are seen in internal medicine or rheumatology or neurology, that you actually can screen for certain autoantibodies, for example. So currently we do not have immune-based risk factors to predict who will get postpartum psychosis or who will get relapse. The other question, whether after postpartum psychosis women get bipolar disorder or not, what is the mechanism there? We think about postpartum psychosis as a disease for which you have a genetic vulnerability, partly overlapping with the genetic vulnerability for bipolar disorder. We know that the genetic vulnerability for bipolar disorder is a vulnerability for getting depressions, a vulnerability for getting mania, and also this is partly overlapping with a general vulnerability of getting psychotic disorders. So the way we think about postpartum psychosis is partly overlapping this vulnerability with bipolar disorder genetically, with other psychotic disorders genetically, and whether you get also episodes at other times in your life. We know clinically that women who had postpartum psychosis might be at higher risk during menopause, also a period of endocrine changes, and some women have a relapse then, but that has not been investigated. For bipolar disorder, there's a recent study from my friend and colleague Ariana Di Florio from the UK showing that women with bipolar disorder are at increased risk of relapse during perimenopause. For this reason, use of hormonal replacement therapy might be useful for these women, but that needs further investigation, and we just submitted a grant proposal on this issue.
I am so glad this work is being done today. I know that there are many women going through menopause who feel like there could be more resources and understanding for that period of life. So, so glad to know that there are active pitches and grants being funded to better understand how to support various women through going through that stage. I'm going to link a study from this colleague, Ariana DeFlorio. One study is a large UK study of over 100,000 women. She looked at the incidence of mania and how it increased by a lot in the perimenopausal window, as well as the risk for major depressive disorder. These increased risks were specific to the perimenopausal period and tended to return to baseline after menopause, which I believe is 12 months after your last period. Don't quote me on that, but that's my understanding. So it spotlights how hormonal transitions like perimenopause are linked with onset of mood disturbances. And there's just a need for clinical awareness and support around various life stages, including menopause. So to recap the conversation, just loved having Dr. Bergink on. We talked about how there is no agreed upon clinician's guide on how to care for postpartum psychosis. It will help to get postpartum psychosis in the DSM to kind of fuel education efforts around postpartum psychosis and awareness of what's best practice. So though we do understand that, using an antipsychotic and a mood stabilizer is generally good, like we talked about with Dr. Berndorf. So I love the idea of getting loud about this, getting loud about advocating for women's healthcare and getting specialized treatment centers here in the US and globally, like supporting systems to take care of families as they are creating life. Sounds like a good idea. An additional plug on this question, is breast best? I loved this flag that in not doing breastfeeding as part of a postpartum care plan, if you are at risk, is wise. Reflects the reality that breastfeeding is demanding. It is, and it doesn't exist in a vacuum. So those who have mental health vulnerability, it's one path to choose, to protect your well-being. There's no single right way to feed a baby. And the most important goal is to care for the whole family through stability, rest, and recovery. So that could involve not breastfeeding. The International Marseille Society that Dr. Bergink referenced, I'll share some links. So MONA, formerly known as the Perinatal Mental Health Society, it's the North American chapter of this International Marseille Society. And they are committed to the advancement of clinical care, research, advocacy, and education in perinatal mental health. They have a lot of resources, and I just wanted to call out a few that I wish I would have known about. The Fussy Baby Network. You can call this number if you are struggling to care for a baby who is crying a lot or having difficulty sleeping or feeding. They have a free support number where you can call for a consultation in English or Spanish. It's 1-888-431-BABY. Sounds awesome. Another is Mother to Baby. It's a website, and they also have a toll-free call line where you can get evidence-based information from healthcare professionals about medications and other exposures during pregnancy. And if you have any questions, you can call, and they have like a fact sheet on medications and knowing what options you have. So you can talk to experts through another phone number. I will link it. It's 1-866-626-6847. And then the last resource I wanted to call out is the National Pregnancy Registry for Psychiatric Drugs. They have a register with information from women who have shared their psychiatric medication use during pregnancy. So they're building a database to understand. I'm sure this can fuel research. And just wanted to say, consider joining. If you have experience with perinatal healthcare, even if you haven't taken medication, you can join and share to contribute. Huge thank you to Dr. Bergink. Loved this conversation. I will also link the article that came from all this work she was talking about to get postpartum psychosis in the DSM. It's called, Make Postpartum Psychosis a Distinct Disorder in the DSM, expert panel says. So that will also be in the show notes so you can read and spread the word. Thank you to Dr. Bergink. Thank you for listening in. Be kind to your mind. Thanks for listening.